great pleasure. We have Ted Trimble and Sylvie Grover from the NCI, and their titles are in the list, but obviously I'll leave it to them to explain to us exactly what they do to make more light of it. So, so Ted, perhaps if I hand things over to you now to fire away.
Sure, Sam, we're ready for our slides.
Yep, I'll just get them now.
I'm happy to share. Okay, great.
And people do use the chat box if you need as well.
Yeah, so welcome. I'm Ted Trimble. I'm a gynae oncologist by training, and my current assignment is to work on behalf of US NCI and US government with all partners on the WHO cervical cancer initiative. One of the people I've worked with very closely is Sylvie Grover. And Sylvie, why don't you introduce yourself?
Sure. Hello, everyone, and thank you, Pat Price and the group for having us. So I am Sylvie Grover. I'm a radiation oncologist by training, and based at, well, faculty at the University of Pennsylvania, but I've actually been based in Botswana since 2014, primarily working on radiotherapy, quality improvement implementation, clinical radiation therapy, as well as, and my research is primarily in cervical cancer, HIV outcomes, and an improvement of care pathways overall. But currently I'm in Sydney because I came here for my second maternity leave and just never left. And during this time I actually met Ted introduced me to some folks at Genesis Care who are doing some really great work in radiotherapy expansion implementation all over the world, with the now new interest, particular interest in low middle income countries. So I've invited Jamie Nash from Genesis Care to join the call as well. And then during my talk, there's an example that I'll discuss that I'll have Jamie expand on a bit. Jamie, do you want to introduce yourself really quickly?
Sure. Hi, everyone. Yes, I'm joined at late notice from Sylvie, so thank you for having me. As Sylvie said, I'm based in Sydney, working with Genesis Care. Some of you may be familiar with Genesis Care, but we are a global oncology provider. Started in Australia, but we now have presence in the UK, US, Spain, and increasingly we're looking at initiatives in other developing markets as well. We were born out of radiation oncology, but now we are across the full spectrum of oncology. And through what we've done in terms of being able to build up our global program, we've, through that, created a way of working that we think can help in building access in other markets as well. So that's some of probably what we wanted to talk to. I think my Sylvie invited us along today as well.
Great, thank you, Jamie. Next slide, please. So I'm going to cover some issues of implementation which could be studied in implementation science, and Sylvie will take the second half of the talk with a more focus on some specific implementation science projects with the help of Jamie. Next slide, please. So this is the official US NCI definition of implementation science. The study of methods to promote the adoption and integration of evidence-based practices, interventions, and policies into routine healthcare and public health settings to improve the impact on population health. So we at USNCI are the leads for our National Institutes of Health and Population Science, and this is an area that we've really spent the last 10 years trying to develop. And so we're proud of what we do, but we think it's critical to make sure that the research that we do actually gets translated into public policy and routine healthcare. Next slide, please. So these are some of what I'm going to cover in my thoughts on implementation, with some comments as to what I've heard about around the world. Next slide, please. So in terms of national, at the national level, clearly it's critical that radiation therapy be part of the National Cancer Control Plan, but also that that plan include things such as surgery, pathology and laboratory medicine, imaging. Also, it's important that they plan, integrate public, private, and faith-based health systems, because we know in many cases, radiation oncology, for example, may first become available in the private setting. And so public-private partnership may be useful. Other issues include the government commitment. Does universal healthcare pay for routine cancer care? And certainly I've heard recently about both in Nigeria and in Bahamas that universal healthcare either does not exist or does not pay for radiation therapy. Is there a regulatory framework for nuclear safety and security? We know that IAEA will not sign off on new equipment unless that is in place. Maintenance contracts are critical. I heard recently about a linear accelerator or their first linear accelerator in Albania, where it broke in the first week, but the Albanian law would not permit an outside maintenance service contract. So it moldered for 20 years before it was finally replaced. Government commitment to consumables, getting things through customs is critical, as well as the public-private partnerships that I mentioned, and the importance of training programs for relevant disciplines. Certainly, I just heard from Ethiopia, for example, that they weren't going, although they have contracts for 5 new linear accelerators, they weren't going to set up any national programs for training, but insisted that the universities where these linear accelerators are going to be based set up their own separate training programs. Next slide, please. Human resources, obviously training is something that we talked about. Also making sure that staff get adequate, reliable salaries, go to their bank accounts every month, opportunities, professional development, and a collegial work environment. So we certainly have heard a lot of occasions or instances where people left because they weren't being paid, their salaries weren't showing up on time, or they were offered better salaries, better working environment in another country or another institution. The equipment, obviously, we mentioned that is critical, and we have to remember that a number of our, let's say, Varian, for example, has been bought by Siemens, which also makes imaging equipment, also makes laboratory equipment. So I think we need to see how we can build on that expertise in the one big company. I talked about maintenance and consumables, also transparency. Too often I hear the story from the clinicians on the ground saying, oh, this machine is broken, we don't know when it's going to be fixed, or we don't know why it's not being fixed. So this is critically important. Next slide, please. The site, obviously electricity is a critical issue. And again, I think here we should be working with Siemens and GE and the other big companies to do a better assessment of electricity reliability, because they know on a day-to-day basis if their machines are working or not. And so we can get a picture. I tried through USAID to see if they had a picture of electricity at the local site. They do not. And I mean, they have national data. In some cases, so I think this is an area that needs more study. Running water, supply chain for consumables, obviously. Access to mobile phone and internet. We've talked a lot about distance learning and distant treatment planning, but we need to make sure that our sites are hooked up to the internet for that. I think we can learn from some examples in pediatric cancer. For example, in Central America, one very good program was able to increase compliance with treatment for pediatric cancer by providing hostel type lodging and food and transportation vouchers for the parents to bring children back. So they were able to improve compliance from about 20% to 90% just with those minor interventions, and access, obviously, to transportation systems to get people, particularly from rural areas, to the treatment site. Next slide, please. Data is critical. We've certainly found that some countries have begun the use of unique personal identifiers. Some countries have begun the transition to electronic patient records, but in many cases, records still are only captured on paper, making questionable whether the data from clinics, from hospitals, cancer registries, and vital statistics can be linked. We really need to sit down with, particularly with Varian Electa, to discuss how best to link the radiation therapy treatment data to hospital treatment data to cancer registries. Another issue that we need to be looking at is the use of imaging to triage patients between palliative care, radiotherapy, for example, and definitive treatment. We may be able to decrease the waiting time for patients getting definitive treatment if we can use imaging effectively to triage there. And there have been obviously a number of efforts to use imaging data for radiation contouring and plan to do that automatically. Next slide, please. And then I think it's also important that we think about the patient experience, whether delays in referral, a need for out-of-pocket expenses. Certainly in the cervical cancer field, we've heard this, that screening may be free, but if a patient needs workup for evaluation for CIN3 or invasive cancer, she and her family have to pay for that. I mentioned what some of the pediatric oncology folks have been able to do and help with transportation, lodging, and food. Are translators available? What are the expectations for family members? In many cases, the family members are expected to bring the food to the patient in the hospital and to essentially take over the nursing care in the hospital. What are the daily waiting times? We certainly have heard stories where everyone getting radiation that day is supposed to show up at 8 a.m. and wait hours to be treated. Is there respect for the patient's dignity and autonomy? Does the patient have an invitation to ask questions and report symptoms? Certainly our colleagues at Tata in Mumbai tell us that they have 5 minutes to talk to each patient, which is obviously frustrating to the patients, frustrating to them, because there's not sufficient time to ask questions or report symptoms. And then is there survivorship care and follow-up after treatment? Next slide, please. So I'll turn things over to Surbi.
Great, thanks, Ted. So I'll go through how to tackle some of these questions using implementation science. And I'll start off with saying that I'm not an implementation scientist by training. This is more just learning on the job and the necessity on the job. I started off as very much a clinical translational researcher, and with the environment that I work on, very quickly realized that actually a big piece of the puzzle and a big piece of the challenge is using the interventions we already know work and really put them in practice to improve patient outcomes. And soon, very quickly, I also realized that there's a whole science behind this, and there's actually a proper way of doing this. It's called implementation science. So I'll talk about a few of the examples on projects that I've been working on, as well as how I can see some of the questions that Ted's brought up and challenges Ted's brought up that we can actually formally study and put in practice. Next slide, Sam. So here I'm just this is the same slide that you saw with Ted, and here just focusing on, the implementation science, a study of methods to promote the adoption and integration of evidence-based practices, interventions, and policies into routine healthcare and public health settings to improve the impact on population health. And that's the key. We can study all we want, all the questions, and develop the interventions, but if we don't know actually how to put them in practice, in the day-to-day practice to improve patient outcomes, we haven't really done our job. Next slide, Sam. So this is a slide from Sudha Sivaram, who's a colleague from Center for Global Health and has worked closely with TED for many years. And she's been really passionate about implementation science in cancer care in low middle income settings. And I think I wanted to just point out, she's really helped me sort of think about how to break down implementation in cancer care. And it starts off with very controlled and observational study to develop some baseline data to understand actually what's going on. And then developing technologies and having evidence that a technology or modality really works. And then taking it into planning for cancer control programs that can then guide implementation of the programs and inform policy. So what does that really mean? Next slide, Sam. So, to me, the way I understand it is first actually having really good baseline data of what's going on in the real world settings. This is sort of what I guess I've been doing a lot in the last few years in Botswana with the clinic that I run. And I'll present some examples, and Ted and I are working on sort of expanding this in Sub-Saharan Africa, in several countries in Sub-Saharan Africa in different phases, working closely with IEA as well as the Varian Foundation, and the first proposed project will be in Zambia. Next slide, Sam. So for example, from Botswana, we have data on cervical cancer patients who've received chemoradiation or surgery, all invasive cancers from 2013 until recently. And so we've looked at, well, what's the breakdown of the different stages that we're getting, as well as what are the outcomes of these patients, and what is the demographic background. So interestingly, 70% of our patients are HIV positive. 75% of our patients are stage 2 or 3. So majority of our patients are getting chemoradiotherapy. It's a very small group that's actually requiring surgery. And overall survival for all comers at 2 years is 67%, and at 5 years is about 56%. So this is a starting point for us to see, all right, any interventions that we build in, how do we actually improve this outcome? Because in the end, this is what we want to look at. Next slide. Using this data further to understand how we're doing in terms of implementation of cervical cancer radiation, we looked closely at what's the breakdown at various time points, how long it's taking for patients to get through care. And this is a sample of about 230 patients, and here's what we saw. That just from when biopsy is done to when the pathology report is published or is reported, so date of diagnosis is about a month. And then from when we receive the pathology report to their first visit where they actually get evaluated and worked up for treatment, it's another month, about 23 days. And then from their first clinic visit to actually getting to the radiotherapy center, because for us, there's patients are seen in the public hospital and then they're transferred to the private hospital for radiotherapy, and there's a lot of paperwork involved. That's 40 days. So already from when the patient actually had the biopsy taken to when they first get to for a consultation for radiotherapy, you're already looking at almost 3 months. And at this point, patient hasn't even started treatment. So this really gave us a lot of information on what are the points of intervention and care navigation that we really need to focus on, and what are our pain points that we need to work on and look closely of why there's such delays. Next slide, Sam. So this is another example. In our clinic, like you saw, most of the patients are presenting with stage 2 or 3 disease, but the current cervical cancer guidelines for the country are patients to be screened HIV positive or negative between the ages of 30 and 49. So what we were interested in was looking at, well, what percent of patients are we seeing in our clinic that would never actually be eligible for those per those screening guidelines? And is it really a big percent? Because we're still continuing to see very young patients, as well as our burden of disease for cervical cancer is not really changing despite really good HIV care. And what we saw from our data is that about 20% of the patients with advanced cervical cancer are presenting at ages younger than 40. And again, majority of those patients are stage 2 or 3 disease that will require chemoradiation. And these patients have never been screened and never, wouldn't be eligible for screening in our system. So this was really helpful data to then sort of say, all right, going back to our policymakers, as well as working with our screening stakeholders to think about, okay, what do we need to change in terms of our screening guidelines, as well as what do we need to do in terms of implementation to get younger patients, given the high burden of HIV in our population, to come through the screening clinics. So here it's just, so here I wanted to just highlight some examples of the sort of baseline data that's really critical and that we need from clinics in order to either evaluate the intervention and then actually develop the intervention. Next slide, Sam. So there's several interventions, and I'm going to mention a few that we've considered, as well as some of the collaborators, colleagues have considered to get at, some of the challenges that I've mentioned in the last few slides. So mHealth is one of them. So in our clinics, we've developed a local application called Outpatient Care, and that's able to send patient reminders as well as serve as a patient EMR system. But every time a patient comes in, the nurse who's evaluating the patient, checking the patient in, has to actually enter some of the basic information. And then the registrar that I'm working with, or the medical officer I'm working with, has to enter, take photos of the patient's charts, as well as enter additional information on their staging and treatment and dates, etc. But this application has really helped, one, track patients through the system, keep track of what their dates are for different appointments, as well as sending them reminders and having feedback from them if they're not able to make the appointment, or they were not able to make the appointment for logistical reasons, etc. So we've done some basic acceptability feasibility studies on it to really get at, if people are even interested in using it, if they find it easy to use it, and the answer is actually yes. So this particular intervention is quite prime to now think about implementation strategies to really integrate it into clinical care and see how it actually impacts outcomes. Another one is through colleagues who've been working at several institutions, working on auto-contouring and auto-planning tools. And some of these are being piloted in Sub-Saharan Africa and India as well. Cloud peer review to, for colleagues at institutions that don't have a peer review themselves, to really get together and review each other's plans, and hopefully, that improves the overall quality. And all of this is done over cloud and doesn't really require a lot of resources. And then several contouring and planning education platforms, some of those that are ongoing through IEA actually, and chart rounds and the RAO's contour education programs. Next slide, Sam. So the next step, now we have the baseline data to understand what the challenges are, what the problem is, and where we are in terms of our baseline outcomes. And then the next point is to actually figure out what the intervention could be. And then, the point that's really critical is to figure out the implementation strategies. And that requires additional training and expertise in qualitative mixed method studies to work with the stakeholders, work with the end customer, consumer, i.e. the patient, and as well as understand the feasibility and acceptability of these interventions, and potentially what are the facilitators and barriers for uptake of these interventions, and then eventually pilot these interventions in a pilot study or an implementation trial. Next slide, Sam. So here, there's one really great example. It hasn't been formally studied, but the Genesis Care Group has done a really great job implementing this, their radiation oncology program in Manila, but then also understanding how, in the short term and long term, this has impacted care in that clinic. So I'll pass it on to Jamie for this slide to expand on it a bit more, because I think this really demonstrates how this could be potentially done on a larger scale.
So just a little bit of background on this is we had been looking at ways in which we could enter new markets, and traditionally Genesis Care as a provider was very much in the model of owning and operating. But I think what we found more and more as we were particularly in Asia looking at markets is sometimes owning and operating the clinic is actually quite difficult and not always possible when working with local partners. But we saw a real need in these markets for how we might be able to help them and provide them with services, but really just enabling their team. So what we sort of brought to bear here in Manila, after a number of visits to the market and meeting lots of different people through our friends at Varian Electa, is finding a local provider who had identified themselves as needing some help and support to provide better care to their patients, but really wanted to retain control of their own local clinical and referrer operational metrics. So ultimately what we did was we put together a program for them where we were able to support them in the background and help support them remotely. This was all through COVID because we weren't able to get into the market So essentially what we developed was a plan in which our operational team based in Australia was able to do some upfront questionnaires to really understand how they're currently providing services in the clinic, working with their doctors and their clinical team and their centre management team as well. And through this, we sort of mapped out ultimately where the gaps were that we thought would be able to help them. And from there, we kind of went back with a plan on how we could support them around a few initiatives. One of them, being helping them, making sure that they had all the equipment and software that they needed to, they had just recently bought a system from Electa, but we just sort of helped configure and optimize some of those areas where we know in our own clinic it's been really beneficial for ourselves. We've helped in terms of remote dosimetry. So we have done a lot of the complex planning for them in terms of IMRT. They'd previously been doing mostly 2D and 3D conformal. Part of it was around time constraints, but also the planners that they had in their centre were very young and new and hadn't had as much experience in being able to do more complex plans. So some of that was then shifted over to our team. We were able to configure a lot of the systems that they already had in a way in which that meant that they could move to a more digital workflow. So really optimizing their EMR solutions and building a BI solution off the back of that, so that they could really see all the data that was being captured real time to be able to make clinical and operational decisions as every day as patients are coming in, which has also then been a huge benefit for the clinical team who are in the clinic every day, and what's meant that they're spending less time doing a lot of the tasks that they had been previously doing, to the point where we have data now that says that a lot of the clinical staff are potentially spending less, can be up to 2 hours less in the clinic per day than they were previously, because a lot of the paper-based tasks and some of the workflows that they had been using before have been able to be made more efficient. And ultimately, I think, as we've also seen, has been a really big upside in this, is a lot of the data that they're now being able to collect, which had previously been very difficult for them, is now in a way in which they can see. And then we've built around that a lot of flags and alert where they haven't captured patient data, but we think it's important for them, it will flag. And then ultimately, when that patient comes in for the next treatment, they know that they need to collect that data. So they're building out this base of data that, from an outcomes perspective, hopefully they'll be able to demonstrate to their patients and their referrers, and hopefully the local payers as well, that they are being able to deliver on these quality outcomes that I think we've found in looking at a lot of these markets, the data is often not there. So this is still a very nascent model for us, but ultimately we would like the opportunity to help in markets where we know that there are a significant undersupply of both doctors and skilled clinicians, and we, working with Varian Electa and other partners, think that there's an opportunity in which we can leverage some of our global network to be able to provide these solutions.
Thanks, Jamie. Next slide, Sam. Great. So there's several other examples of how we can study these interventions to implementation strategies and really assess outcomes. And so a few examples that I've listed here, that Ted and I have discussed at length. Does a focused educational program on contouring planning result in better patient outcomes? There's a routine standardized assessment of patient symptoms at diagnosis and weekly during treatment lead to better symptom management and better compliance with radiotherapy. I mean, these are questions we've just never really looked at in radiotherapy clinics. Specifically, especially in low middle income countries, but it is really critical, because when you think about patient compliance and completion of treatment, that's quite poor. I would say in our clinics, only about 30 to 40% of the patients who actually finish all of their radiotherapy and all of their chemotherapy on time for cervical cancer. Will the use of mobile phone messaging improve patient survivorship and post-treatment follow-up? That's a really big open question as well. Again, we have good, at this point, we have decent quality of life data on patients during treatment, but it certainly falls off during follow-up. And there's actually a current NCI supplement looking at exactly this, looking at, you know, how can survivorship care be improved, and what are the challenges associated with that. So we're hoping to work on that using this mHealth technology that I discussed earlier. Next slide, Sam. So I think, you know, to sum it up, we understand the problems, or I guess we understand problems enough to say, all right, these are the challenges, and we have enumerated them. There's a challenge with workflow, there's challenge with education and training, there's several of the challenges, and we need to continue to do work in that area, but we sort of have a better grasp on what the issues are in low middle income countries now. And there are some potential interventions. So really the next step is to develop feasible implementation strategies and study outcomes and see how we can actually use these strategies to really, and interventions to really improve outcomes for these group of patients. Next slide. There's several potential training and funding opportunities towards this. I've just listed a couple here through the NCI. The link, the cancercontrol.cancer.gov has a bunch of other funding for implementation science, some specifically for cancer, some overall for health, but cancer is included. And then I also want to mention this Training Institute for Dissemination and Implementation Research in Cancer, which is a course through the NCI that's free that one can apply for. It runs through for 6 months. I'm currently doing it. It's only on module 2, but it's quite helpful. But I would highly recommend it for anybody working in low middle income countries interested in implementation science. Next slide. And I will end here, and I think we can open it up for discussion and questions.
Gosh, that was absolutely fantastic. Thank you so much. So people do put hands up in the chat box. So first one from me, actually. So fantastic. This is just what radiotherapy needs. Now, what do you need to make this big happen in low middle income? Is it funding? Is it policy change? Is it will? What would be your big step change to make this really happen? Because this is obviously what it needs, isn't it?
I think it's all of the above, Pat. We know that, we think we need to emphasize both the importance of radiation therapy in for the treatment of cancer, as well as that it's a very complex system, and to make that we have to prove that investments in radiation actually improve patient health, and study what is necessary to make that happen. And certainly we saw in Jamie's example of, look, quality goes up and patient time spent waiting in the clinic goes down and the doctors get home earlier, kind of thing. I mean, those are all good things, kind of thing. So we need to figure out how to use implementation science to address these issues. But we've certainly seen it's not enough just to cut a ribbon on a new linear accelerator. You have to make sure that it's working correctly, and that patients are being treated appropriately, and that patients are getting started, within 60 days of diagnosis, kind of thing. So, there are whole.
And for me, what came through was that it's all based around evidence-based, international standards and transparency, kind of what's not to like, really. So Lisa, perhaps what's your feeling about what would be the first, how would that help to amplify this message? What's your thinking is the gap?
Well, so I'll answer that question, but I actually have a question of my own, Pat. Thank you. And thanks to Surbi, Jamie, and Ted for the presentation, because what I'm curious about is the intersection between everything virtual and everything in country. And, Jamie, you talked about the success in Manila, but what does that transition look like? Is there a transition? So you can imagine, Ted said, you cut the ribbon, you've got the treatment. Do you have all the staff? What staff can be supplemented by remote planning, the remote dosimetry? I'm not a radiation oncologist. And what needs to be on the ground? And is this, I don't want to call it a stopgap, but is this a today solution that looks different in a year or two as maybe staffing and training goes up, or is this a forever solution? Because I think, Pat, I mean, that gets at your question, what do we advertise, what do we ask for, what do we say is the end state? I don't have the answer, but I'm very interested in how do we treat the patients today and build the capacity so that there's one, sustainability, but also ownership. So that was a very long question and statement.
I can talk specifically probably to our thoughts on where we're at the moment, and we have contemplated all these things. COVID has obviously created a unique situation in that remote is really kind of the only thing that's available at the moment. But in doing that, it's probably taught us a lot of things as well. We had been in the market before COVID, so we had met with the local partner. I think that is important, that you need to have a local provider that you can trust and that you can work with, because not having a local person that you can know that is going to actually implement this with you on the ground is going to make it very challenging to get up. But what we've then been able to do is bring in and introduce all of our clinical team who are based in Australia, and most of those relationships have all been done virtually. And the team has, at the start during implementation, it was almost every day kind of conversations, and there was a lot of back and forth, all done virtually. But then it's now moved to sort of weekly and even monthly conversations where there's ongoing support, but we've been able to provide a lot of that background and training materials that we've left with them, but they also know that the team is there available whenever they need them. Our hope and our plan is that this is not just a one-site thing, and it becomes more of a market thing that we're currently looking at the moment. And I think that the reality will be that we realise the importance for it to grow in the market is on the ground resources. So we're also looking at that plan, and how ultimately that might be working with a local provider, but almost even creating some of these centres of excellence in a market where they locally might be able to support more clinics. So rather than having it in every clinic, you might be able to create a central centre of excellence that does some of the planning, also helps with some of the support and services that provided to other clinics, but over time builds up a base level of competency across multiple clinics in the market, but kind of all comes back hopefully to kind of a central clinic, which can then be supported offshore by our team in the US or Australia. But we think it's important over time that there is actually on the ground competency, because you kind of need to ensure that there is that local relationship and that they are building out to, the biggest thing is that in most of these markets that, the number of doctors or physicists or even radiation therapists is very low. And the only way to kind of solve that is actually start now, because it's going to take time. And I guess sort of probably, the final point is, I think what we've looked at and we've seen other providers look at as well is that just having one clinic in one market is okay, but the reality is it needs to build into a deeper program for it to actually succeed in the longer term. So, our thinking and theory is that we prefer to do it well in fewer numbers, fewer markets, and build that up over time to show that there is a model that works, rather than trying to go in shallow in lots of markets and never really kind of actually proving out that there is a way in which the market as a whole can grow and develop.
That's really helpful. So in some ways, from what I got from that is, you need these centres of excellence. You need the sort of the standard that can help. And I suppose, Lisa, your point is that it's slightly about who's in charge of being that and delivering that, as it were, and what do you think industry's role itself, because I suppose across the globe it's in different areas, isn't it? I know there's a lot of industry on the call here, and with the Global Coalition. What do you think, can industry help more? Can they play a greater role, or is it about right? What do people think?
They can absolutely play a greater role. I mean,
Okay.
It's not really about, I think you asked this, Pat, like, it's not about the money, right? What you actually need is the right systems in place and the right people. And often, you know, in any one particular country or region, you're not going to have it all, right? So you're going to have to bring in external partners to bring up that capacity throughout, because we actually need to treat the patients today. We need to set this up today because there's patients dying of cervical cancer and other cancers that need radiotherapy today. But at the same time, that capacity, that, you know, the overall bar has to go up in any particular country. And industry has a huge role to play because they have specific expertise, right? They're usually doing one thing and doing it really well. So there's nothing wrong with different players coming together, that coming in from different angles and different expertise and putting in a system together that solves the problem in that particular country or region.
And do you think then how, in terms of to amplify that message, as we're trying to all, in our different ways, advocate more for radiotherapy, does that also mean and doing it in these ways, adding all those things? Do you think before we've just gone for little bits of the puzzle rather than the overall solution?
Absolutely. I mean, absolutely. Radiotherapy, as much as everybody likes to think, is just a field of these people sitting in bunkers who have PhDs. It's not really, right? It's actually treating real cancer. And in low middle income countries, 70% of all cancer patients are going to need radiotherapy at some point in their cancer care. That's just the bottom line, right? So we don't exist in a silo. Radiotherapy exists in a much larger cancer care context, right? So it requires us to be building all of these aspects at the same time to get the outcomes that we need and to develop and set up sustainable systems that we need. That's the bottom line. And that's not, it can't just be done by buying a LINAC. That's really not the problem. Buying a LINAC is actually really easy. Getting the money and purchasing a LINAC is not that hard. There's vendors for it. You can negotiate prices for it. You know, IEA will help you. Everybody will help you. It's super easy to do that. The problem is actually setting up the system so you can do it sustainably and the patient can get quality care and have decent outcomes. For that, you also need to make sure they have decent pathology and imaging, and they can get in a timely fashion. And, you know, the treatment itself is really good quality. There's good QA, and the machine's not going to be burning a hole in you. And then someone's giving you in evidence concordant care, and then we can measure what your outcome is and feed back into that loop, right? So it's really setting up those systems that exist on the larger path of the cancer care than just the radiotherapy bit, right? So we're actually, even though, you know, radiation oncologists are thought to be just really focused radiotherapists who just aim the beam at the tumor, it's not really the case, and definitely not the case in low middle income countries.
It's interesting that, because again, another question, how can the global coalition help? And certainly our thinking over the last year is involving more of the outer ring of the onion, as it were, the imaging, the pathology, even the, you know, immunotherapy links, that type of thing as well. Mm-hmm. And I think you're right, because we can be a bit geeky ourselves, can't we? Can I please do people put your hands up or shout if you need. I don't want to dominate all this. It's so fascinating. One question I did have is this the opportunity for high income countries as well? Just hearing you talk it through, I'm thinking, I'm not entirely sure the UK isn't acting like a middle income country here because of COVID. We've just done a survey with ourselves, and that survey has just come out in Europe. There's 1 million people undiagnosed in Europe with cancer now. And so the backlog is horrendous. So everybody across the globe is now going to have your problems with not enough staff, not enough, you know, need better workflow. How are we going to do it? In the UK, we've just done a recent survey. You know, in January, our numbers were still 25% down, and that was after nearly a year of COVID. 20% of respondents in the survey didn't have the basic IT to join a teleconference. This is the UK. Okay, we've got electricity, but we don't necessarily. There was one group even said they didn't have a phone in the department to phone the patients. So I'm not entirely sure. Is this an opportunity to get this message over into where we need to reset radiotherapy globally anyway, all across the board in terms of priority? And also now you've got all these technology tools that can jump us up to where we need to be. Is this our moment that we need to do it?
I see Rolando is raising his hand.
Rolando, great.
Yes, thank you. I almost agree with what was saying about how easy it is to buy LINAC, because I don't think it's easy, but really is the easiest part. And I totally agree with that. You can get the funds from time for different ways, but the problem is, in my opinion, is this topic that has been raised now. Is the role of radiotherapy as part of the multidisciplinary approach, not only as the treatment of cancer in general, but also, which is important to promote this awareness and education of all health professionals, but also to educate people as they are, radiation oncologists, are part of the multidisciplinary team. They cannot be any more isolated. I think that has been really creating a lot of problems, and many problems that radiotherapy has, I think, has deal with this situation of they are not feeling part of the whole team, and that you can isolate it, you cannot do nothing. We have been working now a lot with the City Cancer Challenge in this multidisciplinary approach, and we see how people don't know the radiation oncologists. They don't have almost contact sometimes in many cities, and it is important to make them feel like nurses. I think this is the two groups that need to be really get into the team, feel part of the team, and be recognized as part of the team. So that's very important topic you raised. Thank you.
Another issue, I mean, not an issue, but just observation, certainly in high-income countries, we've seen that networks like the MD Anderson network is using this kind of centralized model so that your physicists do the treatment planning centrally, and the local sites, you know, will have a radiation oncologist and a technician, but are in, you know, contact almost minute by minute with the center of excellence. So I think this has, I mean, it's a model that, you know, for example, Jamie may want to comment on, you know, they're working on in, you know, more remote sites in Australia or whatever. I mean, you have the center of excellence, and that you're in touch with the satellite centers, you know, hourly.
Yeah, very much so. And, you know, all in Australia, or now increasingly as we've moved into the US with 21C, there are centers that are always busier and have better staff in them because they are in the more metro areas. And, you know, increasingly, I think we will see that model play out more where technology is able to assist and provide our clinicians the ability to work from metro areas but provide services into more regional areas, whether it be planning. And I think, as you know, Serbi touched on, there's a whole wave of technology coming in, that remote planning and contouring space now, that will definitely be an interesting space to watch in terms of how much will get automated in the future. But I think what we've found in a lot of that is that technology doesn't solve everything. I think there's always a view that technology will be the savior everywhere, but I think the reality is that technology needs people in the background to make sure that it works as well. And a lot of what our model is making sure that that's stitched together properly, and that the people in the background have that the ability to use the technology, but they are able to provide it in a way that actually then works in a clinic, whether that be center of excellence or in a more regional or rural, or even, you know, overseas in markets where they don't necessarily need to be in the clinic, but they're able to leverage things like telehealth or some of these peer review platforms, or, you know, we have some of our own in-house software where it's around creating standardized care plans. And so, you know, where there are centers where there's probably, you know, a shortage of staff, there is a system in which quality can be tracked and measured to make sure that it's operating within, you know, the realms of what we'd be looking at across the global network.
I see Mary G's online as well. Maybe we can ask her to comment on how, you know, Pat's your question about, you know, how we're using this in high income countries.
So yeah, thanks, Serbi. As always, a pleasure to listen to you and to Ted. I think definitely one should be using new technologies to improve access to care and quality of care, and huge potential in high-income countries. We are trying to automate as much of treatment planning because it will reduce cost and allow us to use precision radiotherapy for everybody. And then I recently talked to Supriya Chopra, who said that they at Tata have automated a lot of treatment planning and freed up resources to do MR guided and use other technologies. So by basically, reducing the cost, you can manage within your budget to do more and more sophisticated radiotherapy. And clearly the low and middle income countries can leapfrog and don't have to go through all the painstaking steps in implementing new technologies that we went through. I mean, it's I think radiotherapy is getting simpler and simpler, actually. People sort of think that IMRT and IGRT is more complicated. I think it's actually simpler than the old way of doing things, where you had to sort of imagine things and figure out in your head. Right now, you can see and you can measure, and there are tools that just make it much, much easier. And I think in the next 10 years, considering the sort of rapid development of technologies, it's just going to get simpler and easier, providing that people continue to adopt it and pay a lot of attention to the quality and the quality assurance. The QA is extremely important, and that can be automated too. So anyway, thanks, and nice to see you again, Surabhi, and didn't know you were in Sydney.
Ray, that's great. Just finishing now, what's your plans for the future? NCI, implementation science, what are your barriers? Where are you going? How can everybody help or learn from this? What's your plans for the next few years?
Well, I mean, I think as, one of the things, for example, that we're trying to do is to help make sure that we understand which pieces are in place, which are not in place, to as get people to talk to one another. I mean, I think Rolando mentioned that, the importance of that, but, we need to have imaging in place. We need to have pathology and laboratory medicine in place. You need a functional blood bank. If you have to transfuse your patients, how, is the blood safe, kind of thing? Do they have the right type? Do they have the right tubing, kind of thing? We talked about, use of mobile phone to link sites. We need to be pushing electronic medical records. I mean, almost every LMIC, they'll say, oh, our records are still paper-based, and you have to struggle to get the records from clinic, and they can't automatically link records from, pathology with the radiation oncology. So we have to help countries address this issue, and starting at centers of excellence or whatever, so because they can be the locus of a network for radiation oncology. So, I mean, one of the centers that we're working closely with is Maputo Central Hospital in Mozambique, which is the one cancer hospital for a population of 30 million or something like that. But it can be that network. So we are trying to work with the radiation oncology team on the quality issues. Right now, we're trying to get them a source for their brachytherapy unit to figure out, do they start with 2D planning, 3D planning for their cervical cancer patients. We're also trying to make sure that the pathology lab is working because it burnt down 18 months ago. So we want to make sure that's up to speed. But it's also a country where there's a big U.S. government commitment. We have a huge USAID presence, a huge CDC presence, a huge PEPFAR presence. So how can we leverage our development assistance for health generally for the cancer care system? We're in Mozambique as well. We're partnered with University of Texas MD Anderson, so we have all their expertise, and so we're trying to figure out how to help build both a national cancer system as well as a good center of excellence at Maputo Central Hospital there. So I think that's just an example of we're trying to do on behalf of both NCI and U.S. government, and, you know, in this case, NCI designated cancer centers such as MD Anderson, to get all the partners working together, kind of pulling the boat in the same direction.
No, that's great. No, that's really good. Thank you so much. Any other questions for anybody? Well, that's been absolutely brilliant. It's given us a lot to think about. This is recording, it will be on the website and the slides, and hopefully that's inspired people. And if there's anything going forward we can do to help promote, but you've certainly set us off in the right direction. And can't thank you enough for your presentations today. Okay, to be continued. Okay, you take care now. Thank you everybody for coming.